Welcome back to TMJ Anatomy. This is the second video on TMJ Anatomy, and we're just going to talk a little bit about how we can quantify the forward head posture. Very briefly, we've got the McGregor line that goes from the posterior nasal spine to the occiput, and then we have a line going from the tip of the odontoid to the anterior aspect of the body. And this angle here should be 101 degrees plus or minus 5. So anywhere between 106 degrees and 96 degrees is within normal limits. But you can see if the head goes into posterior cranial rotation and we narrow this space, this angle is going to decrease. Also, also found that there should be an equidistant space between the occiput, C0 and C1, and C1 and C2. So sometimes we'll see these spaces decreased in a forward head posture. Here we see a line dropped from the posterior aspect of the body, a tangent from the posterior aspect of the C2 body, and the posterior inferior angle of C7. And in a normal cervical lordosis, each body should be forward of this straight line. Now we look at someone who has a straight cervical spine compared to normal. And we can see that the angle from the posterior nasium here and the angle from the that's McGregor's plane, and then the odontoid angle here is going to be a much smaller angle than this angle. Also, we see narrowing of the C0, C1 interspinous space and C1, C2 interspinous space. Risk factors for development of temporomandibular joint disorders are difficult to exactly assess because we have a lot of people that walk around with joints that aren't in good position for the disc and with joints that are osteoarthritic, but they don't have any pain. But one of the risk factors we found is hypermobility and generalized hypermobility of the synovial joints, where the patient has hyperextension of the elbows, the knees, and the wrists and fingers. And this is a risk factor for development of temporomandibular joint disorders because the temporomandibular joint is a synovial joint, and this is a systemic problem. So diseases like Ehlers-Danlos syndrome, where we have a collagen disorder that there's more elastic tissue in the collagen, and elastin in the case of Ehlers-Danlos, or filibrin, I believe, is the elastic component in Marfan's disorder. So both collagen disorders that are where there is a feature of generalized hypermobility. So Buckingham did a study where 54% of patients with severe TMD had generalized hypermobility. Westling did a study where parafunction and trauma were okay, but if we add generalized hypermobility, we have more signs and symptoms of temporomandibular dysfunction. And here is our student that was volunteering. So she does not have generalized hypermobility. Maybe a little bit in one elbow and a little bit in this knee. And then the 9th test is that can you touch the floor with the palms of your hands? This is a party trick that you do not want to try at home, but this is something that you should not be able to do. We want the patient to function in their everyday life with 2 knuckles worth of opening, but they should be able to get to 3 knuckles worth of opening, which is going to help them in their dental care, in their oral hygiene, and also for intubation. So mandibular movements, These are the normal mandibular movements. We have depression, which is just opening, where the first phase occurs when the condyle moves underneath the disc, and then the translation of the disc and the condyle together on the articular eminence concludes the remaining amount of opening. Lateral deviation is typically measured in 8 to 10 millimeters. Protrusion, which is just taking the lower jaw forward so the bottom teeth move forward at the top teeth, is 5 to 6, and retrusion is minimal at 2 to 3 millimeters. So resting position of the tongue in the mandible, the tongue is in the soft no position, the lips are together and the teeth are apart. Elevation reverses the opening, and translation occurs during initial closing and rotation during the final closing. We can have trigger points in the temporalis muscle that give the patient the sensation of a toothache, and they may end up in their dentist's office, but the dentist cannot find any structural or neurological problem with the tooth. Trigger points in the masseter, also toothaches, but more on the lower, but can be in the upper molars also, and that's what can give the patient ear symptoms. So in protrusion, we have a bilateral contraction of the pterygoids. We have the internal pterygoid and the external pterygoid, and the reason these are named is by where they attach on the pterygoid plate of the sphenoid bone. Okay, so protrusion is basically both of these muscles working together to pull the condyle forward. So in this particular picture, this is a temporomandibular ligament, and it is on the right side. So the ear is back here and the nose is up here. So we see that the ligament goes from superior to inferior and from anterior to posterior, and there are two different portions. But basically they keep the mandible from moving down and back. The sphenomandibular and the stylomandibular and the sphenomandibular ligaments, both are suspensory ligaments. There is a condition called Eagle's syndrome where the stylomandibular ligament may ossify, and it can restrict range of motion, cause throat pain, and neck pain. So there are the two distinct capsules of the superior and inferior aspect of the TMJ. The superior capsule is very loose, and the lower capsule is smaller and somewhat tightly bound to the mandibular condyles. This is a representation of Rocabato's pain map, where we palpate portions of the synovial on the anterior aspect and the inferior, anterior superior, posterior inferior, and posterior superior. We also will palpate the lateral collateral ligament, and we will do stress tests to the temporomandibular ligament and to the to the bilaminar zone, the retrocondylar space, and the retrodiscal space. The nerve supply to the TM joint is from the trigeminal nerve, and in particular the auricular temporal branch. And because this also goes to the ear, it's another source of ear symptoms for the patient. So the trigeminal nerve supplies the sensory component for the face as well as the muscles of mastication, and the facial nerve, or cranial nerve 7, is for the muscles of facial expression. So the goal of our treatment for physical therapy of the temporomandibular joint is to create equilibrium for the patient relative to the anterior aspect and the posterior aspect of the complex. So anteriorly we have the TM joint, posteriorly we have the craniovertebral complex. So when we have equilibrium between the front and the back of this area, we allow the body to heal itself. Additionally, there needs to be equilibrium of the occlusal surfaces of the teeth, because disequilibrium or occlusal interferences or teeth that don't go together well will create stress and tension on the TM joint and on the neck. And there's Mariano and me a few years ago for both of us. Thanks, that's the end.